Hi, it's Patrik Hutzel from intensivecareathome.com, where we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies at home, and where we also provide tailor-made solutions for hospitals and intensive care units at home, whilst providing quality care for long-term ventilated adults and children with tracheostomies at home. We also provide nursing care at home to otherwise medically complex adults and children at home, including home BIPAP, home CPAP, home tracheostomy care when adults and children are not ventilated, also home TPN, home IV potassium infusions, home IV magnesium infusions, as well as home IV antibiotic infusions. We also provide port management, central line management, PICC line management, Hickman's line management, as well as palliative care at home. That also includes ventilation, weaning. We're also providing our critical care nurses for home care to avoid emergency department readmissions. So besides keeping ICU beds empty, we also keep emergency department beds empty by sending our critical care nurses into the home for PEC tube changes, nasogastric tube changes, tracheostomy tube changes, catheter changes, even cast changes and other things to keep emergency departments empty and keep people at home. So today I actually want to talk about a systemic issue when it comes to long-term ventilation and tracheostomy and the interface of NDIS, hospital care, aged care. It's something that needs to be addressed on a systemic issue. So it's great that most of our clients nowadays are funded through the NDIS. That is a fantastic thing. And whilst the NDIS still has a long way to go, and it's not perfect by any means, and I've been criticizing the NDIS here on my videos as well. There is some funding for most clients now. So that's the good news. The bad news is, and by doing so, the NDIS is clearly keeping ICU beds empty and is taking the pressure off the healthcare system by using services like our service, evidence-based services that are third-party accredited for intensive care at home nursing. Now, the NDIS has a cutoff at the age of 65. If someone gets on the scheme before the age of 65, it'll continue after the age of 65. But the problem here is that there's patients in ICU that are above the age of 65 that are in a similar situation than many NDIS participants. They have a health condition, they have a disability that confines them to a ventilator and a tracheostomy, or a ventilator without a tracheostomy, or a tracheostomy without a ventilator, right? Or they might need home TPN, right? Or they might need IV potassium infusions at home, IV magnesium infusions at home. They might need central line care at home, Hickman's line care at home, port management at home, and central line management at home. So, those issues are not going away because the NDIS is cutting off at the age of 65. And the problem here is that those patients are stuck in ICU and in hospitals for a long time, taking up a lot of money, taking up a lot of resources, and blocking a bed that can be used for someone that needs critical care and needs an ICU bed. Now, what happens in a situation like that is that ICUs often talk about, well, if treatment is continued for someone on a ventilator with a tracheostomy, that, if they can't be weaned off a ventilator, that they won't have any quality of life and that they shouldn't receive treatment and that we should just stop treatment and withdraw treatment because it's quote unquote in the best interest of a patient, right? Well, with what we've been doing with intensive care at home and looking after many long-term ventilated adults and children with tracheostomies, nothing could be further from the truth. There is quality of life at home. And in some situations, there's quality of end of life because we're also providing quality of end of life, i.e. palliative care at home. And would palliative care be better done at home or in a hospital? Well, you know the answer, especially given that 75% of the population wants to die at home if given a choice, and yet less than 15% actually have the option to die at home, right? So there's a big mismatch. Coming back to what's happening in ICU, and I've worked in ICUs for nearly 20 years, or for 20 years in 3 different countries where I worked as a nurse manager for over 5 years. And, I obviously bridged the gap from intensive care to intensive care at home. I've worked in intensive care at home in Germany, nearly 25 years ago, where we were setting up intensive care at home in Germany. So intensive care at home is evidence-based. It's been around for nearly 30 years, since the late 1990s in Germany, and it's been around in Australia since 2012, since our inception, right? And once again, it's evidence-based. It's third-party accredited. No other service provider in Australia in 2024 has achieved intensive care at home accreditation. So we are a unique standout service here, because no other service does what we do and can do what we do by replicating an ICU bed in the community. By replicating an ICU bed in the community, we provide the option for healthcare services to not only free up their ICU beds, but also to cut the cost of the ICU bed by around 50%. Now, the biggest challenge for families or for patients above the age of 65, there are no established funding streams, right? And if you're watching this and you have your loved one in intensive care and they are above the age of 65, or maybe you're watching this and you're stuck in intensive care, or you're at home already, but you don't have sufficient support and your life is at risk because of that, or your life is at risk in ICU because ICU keeps talking about withdrawal of treatment, because they keep talking about no quality of life. Well, I challenge that on any level, right? On any level. And it's a win-win situation to take someone home that's blocking an ICU bed, that has no quality of life in ICU. The families have no quality of life because they spend days and nights in ICU, right? It is a win-win situation to take someone home, cut the cost of an ICU bed by 50%, and free up an ICU bed, free up ICU staff, free up ICU equipment, right? And for the funding body to cut the cost by 50%. Win-win situation. Also, families often can go back to work, right? Which means they're producing an income. They are paying taxes. Once again, there's many positive flow-on effects from intensive care at home services. Now, where's the funding coming from? Well, prior to NDIS, we have also received funding, or our clients have received funding through departments of health, public hospitals directly, or private health funds. So, we need to put the pressure back on to those institutions, right? And keep highlighting the issues in healthcare. And we should not go out there and say, oh, this person won't have any quality of life, and make judgments about that, right? Make life or death judgments about that, because quality of life is possible. All of our clients have community access. All of our clients are surrounded by their families. All of our clients have the quality of life they want and deserve. If they didn't want to leave, they would have indicated that whilst in ICU, right? Yes, some of our clients might even have brain injuries and they're no longer in a position to indicate, but many of our clients that have brain injuries have smiles on their faces and interact with their families really well. It is not up to anyone to make judgments about quality of life, but the individuals and the families. It's up to them. And for ICU teams, think outside of your ICU bed space. Think what's possible in the community. Just because you haven't seen it and you don't know what's possible, keep an open mind, talk to us, and we will show you how we can improve the quality of life, and in some instances, quality of end of life for your family member, for your for your patients in ICU. It's a win-win situation. Part of accreditation standards in hospitals is partnering with consumers. And I don't think you can partner more with consumers than what we do, right? And it needs to flow. It needs to be more than a lip service, because that's what it is at the moment. It's just a lip service, that partnering with consumers is actually not happening on the level that patients and families would expect that in our niche when it comes to long-term ventilation, tracheostomy, getting long-term patients out of ICU and making it a win-win situation. So that's my rant for today. If you are in a situation like that, go back to your Minister of Health, go back to your local member of parliament, go back to your private health insurance, go back to the hospital, put pressure back on them, and we can help you with that. That's what we've been doing from day one. We created funding out of thin air, basically by highlighting the issues, but also by providing a solution that is much more cost effective than any ICU bed, right? Once again, understand the mechanics, understand the business case behind it, but way beyond the business case are the individuals, the patients and the families that are suffering tremendously while they are in ICU, and we can ease some of that suffering by going home, providing the level of care in your home that you want and deserve, right? Someone is paying for the ICU bed, and it's not you, and it's a lot of money, $5,000 to $6,000 per bed day. We charge, we can cut the cost by 50%, and someone would have an interest in paying for that because it's such a high reduction in cost. Now, with intensive care at home, and just one last thing, I mentioned talk to your private health insurance, talk to your local MP, talk to your Minister of Health, in your state or wherever you are, talk to the media, right? Come on this show, I can interview you here. We need to make some noise around this, and we need to put some pressure back on the system and keep highlighting the issues, and that withdrawal of treatment is not an option, right? It's not up to ICUs to decide who should live and who should die. That is up to the individual, and it's also up, I believe, to our Creator and God, and not to health professionals to say tomorrow at 3 o'clock we're going to stop life support and quote unquote make a patient comfortable. That's euphemism for end of life care and letting patients die, and that is not the right way to go. We need to create choice for patients and their families. Now, with intensive care at home, we're currently operating all around Australia in all major capital cities, as well as in regional and rural areas. We are an NDIS approved service provider all around Australia. We are a TAC approved and WorkSafe approved service provider in Victoria, iCare in New South Wales, and IISU in Queensland, as well as the Department of Veteran Affairs approved service provider all around Australia. We also have received funding through public hospitals, departments of health, as well as private health funds. And like I mentioned earlier, we are also sending our critical care nurses into the home or into residential aged care to keep emergency departments empty and avoid emergency department presentations for our clients. If you want that for your loved one, or if you want that for your hospitals, for your residential aged care, reach out to us as well. And if you're at home already, or you're stuck in ICU in a situation like that, or your loved one is stuck in ICU in a situation like that, with tracheostomy, ventilation, no tracheostomy, but BiPAP or CPAP ventilation, home TPN, etc., and you realize you need this help and you need intensive care nurses at home, please reach out to us. We have helped many, many families in those situations to obtain the funding with our advocacy, and to get critical care nurses at home. We're also providing level 2 and level 3 NDA support coordination. If you want to know more about our level 2 and level 3 NDA support coordination, please reach out to us as well. I've done an interview with Amanda Riches, our NDA support coordinator, and I will link towards that below this video. And if you're an NDA support coordinator working for another organization and you're looking for nursing care for your participants, please reach out to us as well. We're also providing NDA specialist nursing assessments, and we're also providing nursing assessments for any other funding body or organization if you need them, especially when it comes to very complex ventilated and tracheostomy clients in the community or in ICU and in hospitals. And if you're an NDI support coordinator struggling with getting nursing care for your participants, please reach out to us as well. Once again, we have been successfully involved in the advocacy of our clients for nursing care at home from day one. And that is also applicable if you're a family member or a patient who can't get nursing care through the NDIS. We can help you with that. And if you're a critical care nurse and you're looking for a career change, we want to hear from you as well. If you have worked in critical care for a minimum of 2 years and you ideally have completed a postgraduate critical care nursing qualification, we want to hear from you. We currently have jobs in Sydney, Melbourne, Brisbane, Albury, Wodonga, Bendigo in country Victoria, as well as in Warragul in country Victoria. We want to hear from you. Please keep in mind we're looking for critical care nurses that want to complement our team. We want to hire staff that give us regular availabilities because that is what our clients want. Our clients want regular staff. That's why we can provide a tailor-made solution for our clients and their families. And that is what we are exactly providing. And if you're an intensive care specialist or ICU consultant, we are currently expanding our medical team. We want to hear from you. Reach out to us here at intensivecarehome.com. If you're an intensive care specialist and you have bed blocks in your ICU, I encourage you to eliminate your bed blocks by using intensive care at home, and we can help you to do that. More importantly, we improve the quality of life and sometimes the quality of end of life for your patients and their families, and you won't even pay for it. And if you're a hospital executive watching this, we also want to hear from you, because once again, we can help you eliminate bed blocks in ICU, ED, respiratory wards, etc. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. If you're in the US or in the UK or in Canada, please reach out to us as well. We can help you there privately. And if you like my YouTube videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have. Share the video with your friends and families. I also do a weekly YouTube live where I answer your questions live on the show, and you will get notification for the YouTube live if you're a subscriber to my YouTube channel or a subscriber to our email newsletter at intensivecareathome.com. Go there and subscribe now. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.